Hello, and welcome to ADEC's special series, In Conversation, addressing COVID-19. I'm your series moderator, Dr. Jill Harrington, coming to you from our nation's capital here in Washington, D.C. Also joining me is Mr. Isaiah Allen, our Executive Director of ADEC, coming to us from Minneapolis, Minnesota. Today in Conversation, we're going to be talking about an intervention known as restorative retelling, as well as resilience in the face of loss. Joining me here today, Dr. Edward, or otherwise known as Ted Reinierson. Dr. Reinierson is the Director of Grief Services at Virginia Mason in Seattle. He's the medical director. He's also the clinical professor of psychiatry at the University of Washington. Dr. Reinierson has spent the majority of his career studying and doing clinical work with violent dying. Joining us here today also is Laura Takis, who is a licensed clinical social worker, a mental health clinician. She also has a master's in public health. Laura is the clinical director of grief services at Virginia Mason Grief Services, and she also does all the training there as well too. So thank you for joining us here today. Ted and Laura, maybe you could just really quickly tell us a little bit about your background and what you've been doing with restorative retelling, and how we'll get on later to talk a little bit about how this might apply to COVID-19.
Hello, I'm Ted Reinierson, and I'm not on the South Island of New Zealand, which the background suggests. I wish I were at times. I'm in Seattle. I've been here since 1972, and I've been studying complicated grief and traumatic grief after violent dying since the late 70s. So one of the reasons that I'm asked to speak on this is because, not necessarily because I'm an authority in terms of knowing a lot, but I've had a lot of experience, more than most people, most clinicians at any rate. So over a period of years, we've worked with over 3,000 families after there's been a violent death from a homicide, a suicide, an accidental dying. And I think that some of what we've learned from that work has definite relevance, particularly the early phase of what people are going through now with this traumatic grief because of the form of the dying. And I could get into that a bit later, but I'd like to pass this over to Laura Takis now.
Sure, thanks, Dr. Reinierson. Thanks, Jill. So before working as the clinical director at Virginia Mason, which I started in 2015, I was working in the Middle East, in particular Jordan, and working with Syrian and Iraqi refugees that were fleeing into Jordan and using restorative retelling. So I've seen this model work and be very successful within all cultural aspects, different religious beliefs, spiritual practices. And so I think that I'm excited to be here and be talking about this and to really see how we can help the folks who are most impacted by COVID.
And I'm very grateful that the two of you can join us here today. I know that we spoke about a week or two ago, and I called you up and said, you know, there's lots of things here in restorative retelling that being trained by the both of you that might be really applicable to those who are either dying because of COVID-19 or people who are dying during the COVID-19 quarantines and social distancing. So Laura, I wanted to kind of start with you and ask you just to educate the audience a little bit about what is restorative retelling.
The model's designed sudden traumatic death and really helps people, survivors, navigate both the trauma and the grief responses that they are experiencing as a result of a traumatic death, which absolutely COVID is. So the people that I'm starting to see, the clients that are starting to see, they're having a lot of imagery, a lot of disturbing images, particularly because they're not able to be with their loved one at the time of death. And so they're beginning to formulate a story about what their experience is for their loved ones and really coming in with distress, a lot of distress that they need help navigating. Usually people are coming to me generally because of the trauma symptoms are so overwhelming to them. Once we kind of get those under control, or at least are able to manage them, then we really start to work with the grief, which is a much longer process, oftentimes lifelong.
So the word traumatic death used to always be sort of synonymous with violent dying and unnatural deaths, homicide, suicide, accidents. But in the last several years, it's sort of been reframed that in any loss, there can sort of be traumatic elements to it. And could you tell us some of those? You just alluded to that. Can you tell us what some of those traumatic elements may be? And I know Dr. Reinierson, please feel free to join in because you might follow up with that as well too.
Yeah, the common elements that I am seeing with the clients that are coming in after a sudden traumatic or a violent death, if you will, like a homicide or a suicide or drug overdose, are similar to those people who are coming in after losing someone who's there's been a long chronic illness. The commonalities are oftentimes the wondering and the kind of I would have, I should have, I could have done something different to have made the dying process or the final moments of the loved one more easy or more comfortable, if you will. So that's one of the main commonalities between a sudden traumatic death, which is, a sudden violent death versus a death that is maybe not necessarily violent, but is absolutely traumatic.
Mm-hmm. A lot of that counterfactual thinking, the what ifs and the guilt that goes along with it. So Dr. Reinierson, restorative retelling is an intervention specifically designed for violent dying. What elements do you think dying from COVID-19, or I want to say in the COVID-19 quarantine, because people are dying of other things. They could be dying of sudden heart attacks, strokes, illnesses in the hospital. What are you seeing that particularly might apply? What elements are particularly violent or unnatural, or things that you've seen in violent or unnatural death that could be applied in this situation?
I think one of the ways to begin talking about this is to appreciate that we process the death of someone to whom we're attached as a story, as a narrative. And our work at any phase of their accommodation involves telling, it involves listening, it involves words. There are two basic narratives that go on after any form of death. One is the narrative of the dying itself, the way that they died, and the process that the family members or loved ones went through with the person if it were a natural death, where they could be a part of that story. And then the story of the living memory of the person and the relationship that we have with that person. And these can sometimes be, particularly if it's a sudden or a traumatic or a violent dying, these can be very dissonant narratives. One you're attracted to in terms of your attachment and the safety and proximity that you felt in that relationship. And then the other in terms of the dying, if it's a traumatic sort of dying, it's aversive, and there's no role for you in it. Usually when there's been a sudden death or a violent death, the family member and the person that was dying didn't have warning that this was going to happen, particularly after a violent death. And so what happens with the family member afterwards is they're left with a vivid, surreal, imaginary replay of what the person was going through at the final moments of their dying. Now, a family member, I can picture them, and I've not worked with anybody directly as yet, so I'm trying to apply what I know about violent dying to what's going on after this calamity with the virus. But just the fact that they're peering through a window and they don't have any duality or voice in what's going on with the whole dying process, that's going to become a complication. Mm. And I think that they might be left with what we see with violent dying, which are reenactment sort of images and fantasies about what the person was feeling, what they wish they could have said. And the importance of doing that is they're left with a dying sort of story that has a role for them in it. So it's a story that belongs to them. But I think that probably after this, there are going to be a number of family members, they're going to be left with flashbacks and images of a story that couldn't really be processed with the other person. And we know that that's a risk factor after violent dying. Reenactment fantasies that are painful and often panic-ridden. So I think it's important at the outset to have this model in mind of retelling, meaning that there are two stories that are being processed at the same time. And the story of the dying takes precedence, and that's probably what most family members are going to be forced to go through initially. And those stories, at least with violent dying, are normative. They will go on for weeks or maybe a month or two. And we can talk about the psychoeducation that has to go on throughout the restorative retelling, but particularly at the outset of the treatment or the support. I think it's important to appreciate that people needing treatment in terms of being disabled from something like this is relatively rare. Only about 10% of people will come in and ask for help. It doesn't mean that they haven't been very symptomatic and upset, but usually they're able to get through this spontaneously and with the support of their family.
Let me ask you a question, Dr. Anderson. Do you think there may be some extra additional vulnerabilities because people are being taken out of the story? Like, so beforehand, before the COVID quarantine, let's say, if a loved one died from homicide or suicide, there may be the ability to have a family funeral, to get together, to go to a support group and be with other people, although that's happening virtually. You know, now loved ones are dying from COVID, or they're dying not of COVID, but families can't put themselves in that narrative. They can't do sometimes the rituals and the rites that they need to do to feel like that's part of their way of being part of the dying story. Do you think there's going to be additional vulnerabilities for loved ones forced to adjust to COVID dying or dying under COVID?
Yes, we certainly have evidence from that, for that with other forms of dying that have been researched, that burial and memorial and having an opportunity to actually go through those sorts of rituals are very important. The other thing that's going on is the spectacle of what's happening. This is often the case after there's been a violent, traumatic death, and particularly with what we're going through as a society and as a world right now, in terms of the spectacle of the economic crisis, the cable news that's going on. We can't really get away from what's happening, and the economic sort of crisis that's going on as well. But this is not a private sort of dying for the family members. This is a public spectacle that they're forced to witness more than to be able to participate in. And this is the other, I think, thing that's quite specific, dimension that's quite specific to violent dying, is the media and the television and the police, and of course, if there's a homicide, the court. And I don't think that's going to be of relevance to what these families are going through. But the whole spectacle of the dying, making it public more than private, is a complicating variable too.
Do you think there'll be a role for stigmatized death? I recently had a colleague who was on, and she's recovering from COVID-19, and she said she's really afraid of the stigma that's going to be associated with either being a COVID-19 survivor or death by COVID-19.
Well, hopefully not. I think the stigma that goes along with homicide is because of it being a fearful, external, willful sort of dying, and that's not going on with the virus, which is external and impersonal. Very different than homicide or suicide, that's related to something willful that's happened. That's particularly stigmatizing. Negligence, which goes along with accidental dying, can sometimes be a complicating variable. And we've certainly heard reference to that about the virus and how we were or were not protected from it. So I think it might be stigmatized in that sense.
Yeah. Her biggest concern was not knowing she was a carrier and carrying this guilt that she might have infected other people unknowingly.
That's right. Yes.
Jill, if I can add to that, the other side of the coin, what I'm hearing from new clients that are not COVID related, the disenfranchised grief around, just as Dr. Reinerson was saying, that this is so in the news and this is what everybody's attention is on, that the disenfranchised grief of other sorts of sudden traumatic death that other people are experiencing, that this can be very even further feelings of isolation.
Good point. Laura, how do you think the model helping survivors, how do you think the RR model will help survivors of COVID or any other traumatic death of a loved one? How do you think the model helps?
I think, as we mentioned earlier, really helping people have a story that is somewhat palpable and accessible in a way that doesn't bring them to their knees, and being able to really bear witness and validate how horrifying these sorts of deaths, these sort of losses are. The model is also very good at helping people stay connected or to reconnect in a way that they didn't think that they would be able to after the death of someone. So helping people to navigate what this new relationship looks like, because it is very much alive and well. That's why they're coming to see us. So I'm distressed about the thought of losing this person. And so restorative retelling goes a long way to help restore and reconnect, keep people connected to their loved one.
And Dr. Reinerson, you talked about the death story, and part of it is the surviving, the family, the loved one is not, there's this dissonance between the death story and the story of the attachment, the love story. How does restorative retelling help bridge that?
Good, I'm glad you asked, because I think it's a central part of the intervention. And I think it will be, as people that are watching this are going to be in a supportive relationship with somebody that's going through this acutely. That is, initially, we want to counterbalance the two narratives. That if the reenactment and remorse fantasies are ascendant when somebody's coming in to see you, what we need to do is to counterbalance that with the meaningful living imagery and story. So that's paramount as we're working with family members after a traumatic grief like this, is to not focus on the dying narrative prematurely. That's going to become a part probably of later treatment, but certainly not within the first weeks or months. And I think the way that to celebrate the living memory of the person from the first visit, at least what I'm comfortable doing, is asking to see a picture of the person. And nowadays, everybody has a picture of whoever died on their phone, and it's usually a smiling, vital sort of image. And then I want to know their name, and I want to know more about them, well before I get into the violent dying or sudden dying sort of narrative. And I want to know their concept of death. What do they believe happens after death? That's terribly important, I think, for any of us that are having to accommodate to any kind of death, but particularly a traumatic death. Is the image, the soul or the spirit of the person somewhere that's more peaceful and separated from all of the trauma that the person that we're working with is feeling? And I can get into some of the other specific effects. I wanted to have Laura have an opportunity to talk about also the work that she's doing with some of the first responders in our hospital who were having to work with these individuals and their families.
Thank you, Dr. Reinerson. So Virginia Mason has set up a task force of sorts made up of a number of disciplines that are generally speaking social workers or nurses or the chaplaincy, the spiritual care department. And we're going to the hardest hit floors in the units and just having some group dialogue about what is going on, what are they experiencing. And interestingly enough, I just had a conversation with the group the task force yesterday. And what we're finding is that people are actually, time is passing and the staff are really finding their way through this. They're calling upon their resilience and it seems to be working because the need for us to be on the floor, to be holding these sort of informal discussions is becoming less and less, which I think really speaks to what our staff are being able to draw upon to help them kind of cope and navigate through this. I think that when we're able to get them into a group, this has been extremely helpful versus individual. They're able to support each other. And I know in some of these other conversations, Jill, that has been discussed about the power of group discussion and holding people and validating other people's stories. And so I think that that's been one of the more powerful things that this task force has been able to bring together to kind of coalesce people to say, we hear you and it is important what you're experiencing.
Especially in healthcare work where, you know, you're supposed to sort of be invulnerable to burnout, in you know, being able to tough it out, being able to sort of soldier on, and bringing the group together can certainly, you know, allow others to shoulder each other's stress, that peer support where you're sharing vulnerability, and just that validation, like, hey, you know, this is stressful and really tough for me too. Opening that ability just to talk about it without it being such a, you know, can be so debilitating to people to feel like they don't have an avenue to share that shared experience with their peers.
Right. We're getting feedback from other types of first responders like funeral home directors, and I think that the outcry, the need to support them as well, because oftentimes they are they're the last folks that are working with the family members, and the family members are gravitating so much to these funeral home directors or the staff in the funeral homes because it was the last time that they were able to be with their loved one. But I hope more is done at some point, that we expand the support to medical staff, which vastly deserve it, but to so many other first responders that we might not be thinking are actually first responders.
You know, every human being has a threshold to where they're overwhelmed by the witnessing or being part of human suffering. And sometimes it can be a stigma that stoicism in certain careers, that you have to really just be able to carry on and not express emotion. It seems in group environments of other peers could be a safer place for people to do that. Why do you think that is?
I think having somebody bear witness and validate what you are experiencing, that having somebody say, yeah, I can understand why you would be so either burned out or distressed or so traumatized by going into work or seeing what you're seeing, doing what you're doing every day. I get it. And one of the things that continues to come back also, and Dr. Reinerson touched upon this a minute ago, that because the whole world is going through this, that is some level of support for some of the clients that I'm working with, that the whole world is experiencing this in one way, shape, or form. And on some level, that's comforting to me. Mm-hmm. It's like a whole world being able to say, I get your pain. Mm-hmm. Or at least I'm trying to understand. Yeah.
It's less personal.
Yeah, absolutely.
So, Dr. Reinerson, why do you, let's get back a little bit before when you were talking about the restorative retelling and sort of the way in which you work with patients. I'm interested in hearing your perspective on it. It sounds like it must be a very guided intervention, because oftentimes after a violent death, family members who are coming in, really that death narrative is so prominent. So you're pretty deliberate in getting them to talk about their loved one's life.
No, I'm not prescriptive. We have a manualized intervention that we've developed, but I never follow that in a rigid sort of way. I think what needs to be respected is time and how idiosyncratic and particular and private each narrative is going to be, the importance of actively listening and getting to know initially the healthier, more resourceful capacities that the patient has before you begin getting into what's been so traumatic. And one of the ways of doing that, because they're dealing with someone that they've lost, is to focus initially on the image of that person that they can live with, rather than the image of the way that the person died that they just disappear in, because they didn't have an opportunity to be there to rescue the person or to deal somehow themselves in a constructive way with what was going on. So I think initially it's important to reinforce the living image of the person and stress management techniques that we're all familiar with, and psychoeducation. And I think understanding something about some of these specifics that we've been outlining of reenactment and normalizing reenactment imagery. In other words, it's not going to be unusual the first couple of weeks that you're going through this to be having these intrusive thoughts about the way that the person died. These are not this isn't anything that's crazy or abnormal or disordered. This is something you might anticipate. I don't know you're going to have it, but don't be distressed if it goes on for a few days. And we have definite indications about when you need to come back and see it. But usually I think when we're seeing someone supportively, we're not offering psychotherapy right away. We're offering psychoeducation and stabilization, and certainly an offer that they should come back and see us in a month or two if things aren't going well, and we can describe what some of that might be, some of those indications. We know that mothers that have lost children are at highest risk, no matter the age of the child, just because of the intensity of the attachment that goes on with that kind of relationship. And obviously people that have had psychiatric disorders or a history of it, of panic attacks and depression, and having to have resources to take care of that sort of problem with medication if it's helped before. But pills are not going to help what these people are going through. There isn't any sort of medication we can give for traumatic grief itself. Their associated problem we can. I think it's important to be guided by their stories, to be guided by their resources of resilience. A question I always ask is, who takes care of you? If there's somebody from the family who's in the waiting room with them, I invite that person in if that's all right with my patient. In other words, to engender resilience and support from a lot of different resources, not just between me and the patient. And I think doing this early on, being more comfortable, being more open. And if someone can't stop telling themselves and you the dying reenactment story, the importance of interrupting them at some point with the message, I'm interrupting you not because I'm being disrespectful or that you don't need to talk, but I don't want you to be all alone while you're going through this. it's important you let me in on the story so that we can begin telling it together, retelling it together, so that, you know, eventually the story changes. We can't change, but the story that that we're forming between the two of us is capable of changing, of widening, of deepening. So these are the, I think, the helpful, hopefully, techniques that we've learned from the restorative retelling that we're able to suggest to workers that are watching this, that are going to be trying to intervene with supportively or with treatment. Of course, we don't know about treatment. We know about treatment with violent death. We have some evidence-based support for that, but I don't know if anybody's worked with a lot of these families as yet.
So without it being prescriptive, which I hear you, and I kind of guided you to that because I wanted to hear that answer, but it definitely sounds like a guided on some principles. I remember being at a lecture with you where you said that before you need to be able to give someone a golden thread before you send them into the abyss. That was one of the things I remember you teaching us in one of our classes. And so restorative retelling, Laura's shaking her head, is kind of, the method is kind of guided by some of these principles. Laura, do you want to maybe add to that?
Sure. Dr. Reinerson and I practice very similarly. So he's covered a lot of what my first 5 or 6 sessions might look like. I also have a discussion with them about what they've learned about grieving and how the expression of grief, and are they practicing the same way? So, for example, we often hear by my male clients that, you know, I was told, you know, pull yourself up by your bootstraps, you know, don't cry over this. There's really no expression of grief other than maybe get angry. And so having a discussion about, is that how you're grieving now? Is this working for you? Are there other people in your life that might be grieving differently that you're having difficulty with? So looking at other relationships that are still alive and well, and seeing if this is helpful for them or not. Oftentimes family members, for example, mothers that I work with, that they will be telling me that their spouses or their children are grieving very differently than they are, and how frustrating and feeling isolating that can feel. And so having a genuine discussion about that, and an open discussion about the different ways that people grieve is, I think, vastly important for them, going along with the psychoeducation that Dr. Anderson was saying.
So how do you foster resilience or resilient reinforcement during your early support?
It's interesting you bring up the golden thread. And I found...
I'm in there.
No, what I'm getting at is that with all of the training that I've done over the years, I've been impressed with the importance of keeping things very simple and very clear. Obviously, they aren't simple or clear with something like this, but I think it's important to present clear, concise kind of models, because those are the models I explain to my patients. I don't think it's helpful to have a model that's too complex if you can't explain it. I'm not talking about explaining it to other clinicians, which is important, but more important to be able to put some of what I've hopefully talked about in a simple sort of way, simple enough that I could get these messages across to patients as I'm working with them. And the model of the golden thread is something that comes from myths, from the myth of Theseus. Remember, Theseus ends up going down into the labyrinth to rescue these maidens that are there with the dark image of the bull, who's going to tear everyone apart. And as Theseus is going down into this dark, dismal, despairing image of violent dying, Adriani and they have fallen in love, of course, often happens in a myth. She gives him the end of a golden thread that he carries all the way down into the depths of the labyrinth. And once he kills the bull, rather than remaining sequestered in this image of violent dying and darkness, he has a golden thread that takes him back to meaning and purpose and a recommitment to a different sort of life, but to a life. And I think it's an excellent metaphor for what we're trying to do with restorative retelling, which is to help to lift people out of this dark, chaotic, meaningless sort of narrative of the dying back to life. Mm. So I hope that helps other people to remember what I think is primary about this sort of intervention.
I know, Laura, you might continue with ADEC to do some other trainings. I know this year you're supposed to be at the conference that we got canceled and rescheduled for next year, doing some trainings on restorative retelling. And we'll talk a little bit about that as we're closing, but you know, how do you build resilience from the beginning, Dr. Reinierson? I mean, it must be so difficult. I know for me it is. When people come in, they really want to, a lot of times, talk about the dying story right away and the trauma of the dying story. So what are you doing to help build stabilization and resilience in those first couple of sessions?
Well, the first session, I'm listening very closely as we begin to talk about the dying sort of imagery and the living sort of imagery, about how they're able to process that. And some patients aren't able to, there are 3 P's that go on, I think, with resilience. One is called pacification, which is the capacity to stabilize yourself as you're beginning to talk about, particularly the traumatic sort of imagery. And if people aren't able to stabilize themselves, they feel they're disintegrating as they begin talking about it, they actually might get up and leave. And that's not uncommon for us to see people that have left other therapists' offices and groups because they weren't prepared to begin talking about this, and people got into it too quickly. So pacification, the capacity of being able to maintain your own boundaries as you talk about this without falling apart. The second is partition, which is the capacity to establish some sort of experiential membrane between yourself and what's happened. And if people don't have that membrane, sometimes they can't stop talking because they're so immersed in the story that they're telling. Those are the people that are important to interrupt, I think, and to help them to reestablish the capacity for some boundaries through, time-tested techniques of guided imagery and finding a safe place within them. And finally, perspective, which is the 3rd P, which is allowing time to penetrate this experience so that they can carry it forward. So it's not fixed in the here and now all the time. So they aren't stuck in it. And I think that comes from retelling. Having the capacity of going over and over and over this story in a therapeutic way so that they can, rather than being impacted in the story, rather than being impacted in the base of the labyrinth, that they can begin to pull themselves out of it into the future. So those 3 Ps, which I've written about, I think are important. And that's what goes on with any kind of shorter term grief or trauma therapy, is that there are triad stages at any rate. Initially it's stabilization, building up trust, and then you get into a middle phase of bringing to the imagery of the person when they were alive back. And eventually with the therapy at 6 or 9 months, you might get into the sort of the traumatic imagery, but I don't want to get into that now, but that's part of the intervention.
So it's kind of what I hear you saying. It's phased work. Laura, in the beginning, what are you looking for? I know maybe to add on to what Dr. Rynearson said about psychoeducation, just some of the strategies you're using, and how hard is it when the person is talking mainly about the death story? What do you do?
Very similar. If somebody's getting lost in their story and what that might look like as they start to become panicked or start to dissociate, then I will stop them very similarly and tell them with the message that I just don't want you to get lost in your story and feel alone with this. So I'm going to slow you down, and this is part of my role. Reminding them that everything that they have to say is important and part of their therapeutic process, but I want them to be able to self-soothe so they can see that doing the sort of work that they're going to be doing with restorative retelling, that they can be successful at it. I also ask them in terms of resilience, I ask them in the first session or so, if they've had an experience like this before. Have they ever had a sudden traumatic death? And if they have, what did they pull upon at that time to help them get through it? And is that something that they can go back to and kind of reach to help them get through this death? And also bringing in the deceased, bringing in the loved one, and say, how would he or she help you? What words that come to mind that you're able to hear them say to you to help you get through this? And more often than not, they're able to say something. They're able to think of something that Joe might say to me, you're going to be okay. I'm in a better place, or I'm in a good place, or I am okay, and you will be too. So this is coming from the client, of course, but more often than not, they are able to bring words of their loved one back, and that's really helpful.
So you're listening in for strengths and resilience and past experiences in those even just first initial sessions.
Yeah, absolutely.
And you're also educating people about the process while you're doing it. Like you and Dr. Rynearson said, when you interrupt, you let them know why.
Mm-hmm. Mm-hmm. And the individual and group, the model, I do the same thing in my group model, my group work as well. And so so everybody's hearing the message that everything that you want to say is important, and you will have time to tell your story. You don't have to tell it all in the first session or even the first 2 or 3, 4 sessions. There will be time for it.
Important.
Yeah.
Well, anything that we left out today that the two of you would like to tell the audience here today about restorative retelling and resilience? Anything you think, and what's going on right now? Anything worth mentioning that we've left out?
Yeah. I think it's important that you master some sort of competence in dealing with traumatic grief. I think every clinician needs to know this, because at some point in their practice, they're not only going to be treating somebody with prolonged grief, but they're going to be treating somebody with prolonged grief that's gone through a traumatic dying. I don't mean to suggest, I know prolonged grief has just been ordained as a DSM disorder. I don't think that traumatic grief is a separable sort of disorder, but it is separable in terms of some of its effects. We have a manualized intervention that we've tested. So if people like Kathy Shear and Chris Lane and I'm blocking on her name, who have developed interventions, and Allison Salome, who developed interventions for children. But I think it's important that you know about this literature, which we will be glad to provide, and also about the sort of training that we have available. You can download our manual from our website at no charge. So that this isn't anything that we're trying to make money from. I feel it very important that we offer our sort of thoughts and our models to people and to make them comfortable with adapting our work to whatever setting they are in, because I think every setting has a different sort of assumption culturally and socially, and a model isn't going to work unless the person who's delivering the model is comfortable doing it. And they might want to inject certain of their own exercises that they found to be effective. So I think our model is one that points out some referent points rather than a rigid thing that needs to be followed. We've not done that sort of research. We're not in a position to be able to do that. It was Julie Kaplow, was down in Houston, was the other person that I was thinking. There's wonderful work with children in terms of manualized intervention, much better than has been done with adults. But I wanted Laura to have an opportunity to talk a bit about her trainings, because she's gotten much more active in that in recent years.
Right. So we do offer trainings that we have a one-day training, which is really an introduction to restorative retelling, and then a two full day training that it really goes in depth about all of the different techniques that I use, and I'm pulling a lot from my own experience with clients. We show a lot of, I provide instruction by showing a lot of videos of my clients that I've worked with, and I'm thrilled to say that it has been a great success for me to be able to offer trainings not only in Seattle but around the country and up in Canada. And I think in large part it is because it is so flexible. I'm often asked that question about, this is the type of work that I'm doing, do you think this is applicable? And I say absolutely. If you can be flexible, if your clients are, if you're willing to think a bit out of the box and work it to your clients' needs, absolutely. So I think that's been a very positive draw for people to come and get so much training on restorative retelling. But the best way to really is just to look at our website, like Dr. Reinierson had just alluded to, the Virginia Mason Grief Services website, and there's lists of trainings that we provide. Unfortunately, because of COVID and the social distancing, I've made a very difficult decision to put them on hold, because this really, to train the model the way that I train it, it's not conducive to have it kind of virtual or over a Zoom platform. So they've been put on hold until whenever we can start gathering again. But I'm always happy to have people call me and ask me about the intervention and help them walk through it once they've received the training from me. I'm available for consult at any time.
We are so fortunate to have both of you here today at ADEC in conversation. I know that Dr. Reinierson, you've been a big advocate and on the forefront of the intersection of trauma and violent dying. That this is a specialty area that really practitioners need additional training on, so that they don't do any harm to folks that may come into their office. And I'm so glad that you're offering these trainings to folks. And Laura, thank you so much for all the work you've done and for being here with us today, volunteering your time. I know that Seattle's been hit pretty hard by this disease. And so taking time out of your really busy day and schedule to come talk to us about restorative retelling and resilience in the face of COVID-19. So I wish you both well and be safe. And for all those listening out there, thank you for tuning in. And please practice good social distancing measures and wash your hands. On behalf of ADEC, thank you for joining us in conversation.